My topic today is asthma in the elderly, and in fact currently people are quite interested in the idea that asthma exists in various phenotypes, that it's a heterogeneous disease, and the notion that asthma in the elderly might be a phenotype has emerged in the literature, although I think, as you will see from what I have to say, that it is part of a continuum and not a distinct entity in its own right. So, asthma, first of all, it's important to realize, occurs throughout life, and I think we sometimes forget that asthma can occur in elderly. I haven't defined for you what elderly is because it's becoming a sensitive issue for myself at this point. It's like middle age. We always said middle age was 10 years older than you are, but so in this case I'll say that elderly is 10 years older than I am. There's a trend actually for an increase in incidence of asthma with age. The 5-year incidence of newly diagnosed asthma in adults over 65 is estimated to be about 1 in 1,000. Clearly it's underdiagnosed in the elderly, where we tend to suspect other problems, and it can on occasions have overlapping features with chronic obstructive pulmonary disease. But of particular interest, the mortality from this disease continues to be high. Now, a major issue, in fact, is that asthma is superimposed on an aging respiratory system. And so some of the effects of age can have profound effects on the clinical manifestations of asthma. So here in the first panel on the left, we're looking at the elastic properties of the lung. This is lung volume, and this is the pressure, transpulmonary pressure across the lung. And as you go from younger age to older age, there's a progressive loss in the elasticity of the lungs. So in a sense, this is a characteristic that is reminiscent of the changes you expect with COPD or with emphysema. On the other hand, the rib cage becomes stiffer, so this is compliance of the rib cage. It comes down with age. The overall chest wall compliance comes down. And of course, the chest wall is made up of rib cage and the diaphragm abdomen compartments, and this also gets a bit stiffer. So the chest wall is stiffer and the lungs are floppier. And of course, the lung parenchyma, in fact, tends to simplify. So in a very elderly individual, this is an image from a 100-year-old subject that was published recently, and it shows you a simplification of the lung architecture. The alveolar spaces are large compared to the lung parenchyma of the young adult. Now, of course, if you have an increase in airspace size, you will have less air-liquid interface surface. Therefore, you will have a loss of a lung recoil. And this has effects on lung volume, for example. Here we have the typical representation of lung volume with tidal volume, total lung capacity, functional residual capacity, and the residual volume. So with age, the residual volume rises and is a reflection of progressive air trapping. The FRC goes up a little bit, not too much, and total lung capacity doesn't change very much. Now, the change in lung elastic recoil has an immediate impact on the expiratory flows from the lungs of older subjects. Here you have the flow volume curve from a young subject showing you a nice linear descent during expiration. The older subject has this typical concave upwards scooped flow volume curve indicating that there's obstruction. And of course, the FEV1, FVC over time declines as a function of age. Now this shows you the effects of age on the FEV1, and the red line here is for healthy, non-asthmatic, non-smoking subjects. Of course, there's a decline in the FEV1 with age. Then if individuals smoke, there's on average an accelerated decline. Subjects with asthma have lower lung function, and this is the trajectory if they don't smoke. But if they smoke, the lung function or the FEV1 will be expected to decline more rapidly. Now, it's curious that the prevalence of smoking among asthmatics is actually very similar in most studies to the general population. So even though they have a lung disease, they don't necessarily adjust their smoking habits. There are also effects on the immunology, in particular in relationship to IgE, and therefore this would make you wonder about the role of allergy and atopy as a function of age in asthma. What we can see here is that in fact males have and females have declining IgE over time. However, if one looks at asthmatics, the asthmatics will in general have elevated IgE when it's corrected for age, so that they're more likely to have an elevated IgE if they are asthmatic. So this has led to the idea that in a sense the old notion of intrinsic asthma being associated with older age and extrinsic asthma being a disease of the young doesn't seem to hold true, but in fact we have a continuum of the immune processes as well across age. Now, and this is just to show that if subjects have a high IgE, that this is associated with the FEV1-FVC ratio. So these are never smokers and these are current smokers. Non-asthmatics have a FEV1-FVC that is higher, obviously, than the asthmatics. And whether they have a high IgE or a low IgE doesn't make much of a difference. But if they're asthmatic, the low IgE ones have better lung function than those that have high IgE, suggesting that it has a role still across the ages, right up into the elderly age bracket as well. Now, people have tried to look for distinct clinical asthma phenotypes, and cluster analysis has been applied and published. And this cluster analysis, which was done from a primary care asthma cohort plus a secondary care asthma cohort from Britain, identified two groups that were later onset asthma: the obese, non-eosinophilic, largely female, and then there was also a late onset male group, largely male group. And the differences were that the obese female predominant group had a lot of symptoms, but not too much airway inflammation as reflected by eosinophilia in the sputum, whereas the males had a very inflammation predominant disease, but not too many symptoms. But there is not a clear evidence that elderly asthmatics fall out as a distinct population or subgroup phenotype of asthma. So the males had mainly had few daily symptoms and very active airway inflammation. And if they had a lot of sputum eosinophilia, it was associated with frequent asthma episodes, symptoms, and also exacerbations, often associated with chronic rhinosinusitis, nasal polyps, and in some cases aspirin sensitivity, and poorer lung function. So that's that sort of male group. Then there was the obese female group, predominant group, with less atopy, but requiring a lot of healthcare utilization because of the symptoms associated. A tendency to use a lot of medications as well. Now, a second phenotype clustering exercise was published from the States, looking at severe asthmatics, and here they actually divided up their asthmatics on the basis of lung function, pre and post bronchodilator, and the age of onset of the disease. So there were very few criteria used to actually distinguish these clusters. And they did find that they had two clusters that seemed to be distinguished on the basis of age, one under 40 and one over 40. But they weren't the most severe clusters of disease. The severer clusters tended to be clusters 4 and 5. So again, not a strong relationship between the age of onset of disease and the behavior clinically. Now, there's been some attention to the issue of inflammation in asthma at different ages, and this is shows you the different types of inflammation you can expect. First of all, you can have eosinophilic inflammation in the sputum. You can have neutrophilic inflammation. You can have a mixture of the two forms of cells, or you can have very few inflammatory cells where you have mainly macrophages present. So these have been proposed as being different sort of inflammatory phenotypes, but they don't actually relate very well to the activity of disease. And in this initial publication, it was suggested that the only factor that associated with having excess neutrophilia in particular was the older age group. So neutrophilia and neutrophilic asthma was associated with being older, and also this sort of mixed picture of eosinophils and neutrophils. But there was no association between any other characteristics of the disease. And in fact, when a subsequent study looked at the neutrophilia in the sputum of elderly asthmatics, they found that in fact there was no difference between healthy, a sort of mild asthma and healthy elderly individuals in terms of sputum neutrophilia. So in fact the suggestion that neutrophils were associated with older asthma was based on an observation that didn't actually look at the normal population. So as you get older, you have more neutrophils in your sputum. And here this sort of shows you that there are trends over time from young asthmatics to middle age to elderly in the distribution of the inflammatory cells in the sputum, in that in the older subjects there is less eosinophilic asthma compared to the young subjects, and there is an increase in the proportion of neutrophils in the sputum. So there is a bit of a shift in the inflammation, but it's not that striking. And this shows you that if you look at elderly asthmatics only, and you now look at them as either severe, moderate, or mild, you can see the severes up top here. Very few of them have very little inflammation. So the dominant phenomenon is that there are neutrophils, eosinophils, or mixed inflammation in the severe asthmatics among the elderly. So it tends to be richly inflammatory, whereas in younger subjects you have categories of individuals that have very little inflammation but have a lot of disease, presumably more reactive smooth muscle. So we had our own asthma cohort, which we call the difficult to treat asthma cohort, and we had about 70 severe patients and 34 moderate patients. And we observed them over 1 year of time. So this is an observational study, and we measured a variety of outcomes on these patients. We assessed their lung function, we assessed sputum inflammation, and we follow them monthly if they were severe, and we saw them every 3 months if they were moderate. Now, as you can imagine, the age actually spanned from young subjects to subjects that were over 75, and they were slightly older in the severe group than in the moderate group. Age of onset of disease was actually fairly similar. Sex distribution was a little bit different, but this just depends on how you select your subjects. No difference in obesity rates. The ex-smokers were actually more in the moderates than in the severes, so the severes seem to have avoided smoking earlier on. Lung function was worse, with an FEV1 of about 65% in the severes. The ratio was obstructive, and there were some differences in atopy. There was slightly less atopy in the severes, very high rates, like 91% in the moderates. So we looked at things as a function of age. So these are not the loveliest of graphs, but you can see every single subject and every single measurement of FEV1 for those subjects over time. So that we're looking at the age of the subjects here and the dependence of the FEV1 on age. And you can see that there is a slight downward trend, which reaches statistical significance, but it's not very strong. When we looked at other things like sputum eosinophils, for example, we didn't find any relationship. There's a very mixed picture of sputum eosinophilia as a function of age. Likewise, we did not find the expected increase in neutrophils. There were subjects that could have almost 100% of neutrophils, whether they were young or old, in their sputum. The asthma control questionnaire was also not significantly related to age, so that subjects were just as severe young as they were old in this particular cohort. Nitric oxide also didn't vary. It was elevated in these subjects, exhaled nitric oxide, but it didn't change with age, and there are other studies that have shown that as well. The probability of developing an exacerbation of asthma as a function of age was also not significant, so that the likelihood of exacerbation did not increase in our subjects with age. So in a sense, it doesn't seem like there's a distinct entity of asthma in the elderly. It's just simply part of the spectrum, and young asthmatics do eventually become old asthmatics, and it still seems to be rather, the disease seems to be pretty much the same. However, there are common comorbidities that one needs to consider. For example, obesity tends to increase, and this leads to more symptoms and more impairment, even if there is no actual worsening of the intrinsic underlying process. Simply breathing at a lower lung volume because of obesity and also carrying the weight around will increase symptoms of dyspnea, and will increase airway narrowing in those subjects. We also know that obstructive sleep apnea increases with age, and we know, of course, that it increases with asthma. So in asthmatics, particularly those that have a lot of upper airway disease, we can anticipate a very high rate of obstructive sleep apnea, so we should give this some consideration. If individuals have symptomatic gastroesophageal reflux disease, then this, of course, may also be making things a little bit worse, although there's not a strong relationship between this phenomenon and the activity of disease in general. However, a lot of older subjects are now at the extreme of age when we're talking about subjects that are asthmatic and are in their 80s or approaching 90, as we do have them. Problems with swallowing and recurrent aspiration start to be important, and this is something that we also need to be mindful of, as we can treat the asthma very vigorously, but in fact the individuals are actually suffering from aspiration, mucus hypersecretion, etc. from this phenomenon. Then, of course, there are drugs that are given to older people that can have effects. For example, administration of beta blockers to individuals with glaucoma can be problematic, even though you might think that this would not make asthma worse. It certainly can do. And prostaglandins are a preferred drug in this, under these circumstances. Of course, paroxysmal atrial fibrillation is extremely common and increasing in prevalence, and cardiologists happily give non-selective, they give sotalol, which is relatively non-selective and causes problems for us because we cannot convince them necessarily to remove the drug, but this can certainly worsen the disease. So we have to be aware that concomitant drugs may be a problem for us. If patients develop cognitive impairment, it can be very difficult to really know whether they're adherent to their medication. And this, of course, is something that we need to assess. And we may need the help of a family member, for example, to make sure that the medications are taken on a regular basis. Now, other points, I think, that are of importance to stress in relationship to asthma in the elderly are that we need to use objective evidence to confirm asthma. So there's a tendency to call individuals that are older and have symptoms of obstructive lung disease, to call them COPD, and dismiss the diagnosis at that. And this sometimes leads to under-medication, particularly the failure to give appropriate inhaled corticosteroid therapy. I've mentioned the issue of comorbidities and their importance and the adverse effects of treatment for these comorbidities. Of course, also we have to balance our treatment with the adverse effects. For example, the use of very high-dose steroids in very elderly asthmatics is certainly something that has to be done carefully because it can lead to adverse effects on mentation and also to mood changes and sometimes even psychosis. Subjects that have cognitive impairment, of course, will pose a problem in terms of adherence to medication. Now, manual dexterity, also the ability to use the inhaler devices, is an issue, and this needs to be checked very carefully. And it's interesting in that regard that there are demonstrated high failure rates for the use of dry powder inhalers with elderly asthmatics. The other issue, of course, is polypharmacy. So when individuals have 20 medications that they've been given, then the likelihood that they will not take their respiratory medication increases, despite the fact that it's simply inhaled rather than tablet form. So I would conclude by saying that asthma certainly occurs de novo at all ages, and we have to obviously get that message out there, so we should not be surprised if an individual develops asthma at the age of 65 or 70. Patients themselves are often surprised because they believe that, of course, it's a heritable disease, so why would they develop asthma at older age? Clearly, it seems to be triggered by the development of severe respiratory viral infections. Now, the immune basis actually may be different, and that studies have been done not in the very elderly, but in late onset asthma, but at a younger age, showing that the eosinophilic inflammation seems to be less dependent on T lymphocyte infiltration of the airways. So there may be some fundamental differences, but the treatment remains the same as the treatment for asthma at all other ages. Education of the patient, it may be more difficult and will require repeated sessions. Written action plans are particularly important because older individuals often will not take possession of their disease. If you tell them to take X or Y medication when they have this or that problem, sometimes it's a little confusing for them and it needs to be written down so they understand it. And of course, they may need support from the medical team, particularly if you have asthma educators or nurses that help you with your medical practice. This is very, very useful so they can be in touch with the patients. And of course, sometimes you may need to educate a family member who will then make sure that the patient is taking the appropriate medications. So I will stop there and thank you very much for your attention.
Thank you, Dr. Jim, for this excellent lecture. We'll leave the question at the end, especially that you're going to give us another lecture. I have the pleasure to present to you Dr. Hamzawi. She was born in Tunisia. She's a respiratory disease specialist, professor at the Medical School of Tunis, head of the Department of Pediatric Respiratory Diseases at Abderrahmane Mami Hospital in Tunisia. She's an associate professor in Paris 2, France, president of the Tunisian Society of Pediatric Pulmonology and Allergology, and head of the scientific committee of the Tunisian Society of Respiratory Diseases and Allergology. I would like to welcome you here in Lebanon, Dr. Hamzawi.
Thank you very much. Merci beaucoup. Je voudrais d'abord vous remercier de m'avoir invité. C'est extraordinaire pour moi d'être dans un aussi beau pays. Surtout que nous avons tendance à considérer le Liban un peu comme la terre de nos ancêtres. Donc nous allons complètement retourner en arrière pour parler des enfants, là, puisque je dois parler de l'asthme du petit enfant et du tout petit enfant particulièrement. Alors, il y a quelque chose de particulier à l'enfant, c'est déjà la structure bronchique qui est différente de celle des adultes. Bien sûr, ce sont de toutes petites bronches. Elles sont beaucoup plus souples, donc elles ont tendance à se fermer beaucoup plus facilement à l'expiration. Il y a des phénomènes inflammatoires qui sont déclenchés par les infections virales le plus souvent. Et finalement, la bronchoconstriction, la part d'obstruction liée à la fermeture du muscle bronchique est relativement faible par rapport à ce qui se passe chez l'adulte. Tout ça, ça fait que quand on parle d'asthme chez l'enfant, la question est toujours, est-ce qu'on parle vraiment de la maladie asthmatique ou est-ce qu'on met dans le même paquet beaucoup de choses différentes? C'est peut-être ce qui se passe aussi chez les sujets âgés. Après avoir longtemps parlé d'asthme du nourrisson, les gens se sont remis en question et ont commencé à parler de sifflements récidivants chez l'enfant. Donc des enfants qui ont tendance à faire des épisodes sifflants à répétition. Ça a été longtemps accepté en se disant oui, il vaut mieux parler de sifflements récidivants parce que quand on parle d'asthme, on a l'impression d'avoir un préjugé et donc d'arriver dans une maladie qui est une maladie établie. Sauf que quand on parle simplement de sifflements récidivants, on banalise beaucoup les choses. Et on a tendance à sous-traiter ces enfants en se disant bon, ils ont des petits sifflements de l'enfant. Donc c'est quelque chose qui n'est pas vraiment résolu et qui pose aussi un problème dans la définition et dans le diagnostic. Le diagnostic de l'asthme chez le petit enfant, c'est un diagnostic essentiellement clinique. On va se dire comment poser un diagnostic? Alors, clinique, c'est essentiellement, pour commencer, les sifflements. Le problème, c'est qu'il y a beaucoup de choses qui font siffler les enfants et que selon les populations, on a 30 à 50% des nourrissons qui ont au moins sifflé une fois avant d'avoir 3 ans. Donc ça fait une fréquence énorme quand on aboutit ensuite à une fréquence d'asthme chez l'enfant entre 5 et 10%. Donc effectivement, ça a l'air d'être insuffisant comme définition. Le deuxième argument essentiel sur lequel on se base pour poser le diagnostic, disons, d'asthme du nourrisson, c'est la réponse au traitement. Ça pose un problème qui est, 1, quelle est l'efficacité du traitement? Et 2, quand on dit que l'enfant n'a pas répondu au traitement, est-ce qu'on est sûr qu'il l'a bien pris? Est-ce que la maman a été suffisamment convaincue par vos explications pour lui mettre son traitement régulièrement? Et tout ça, ça fait que finalement, chez les petits-enfants, on a abouti d'un côté à un sur et de l'autre à un sous-diagnostic. Après avoir longtemps parlé de sifflement récidivant, on s'est aperçu que ce n'était peut-être pas une superbe définition, parce que la question est de quoi on parle quand on parle de sifflement. Est-ce que ce que considèrent les médecins comme étant des sifflements est ce qui est rapporté par les parents quand on parle de sifflement déjà? Et puis finalement, ce ne sont probablement pas les sifflements qui sont les signes les plus fréquents chez les petits-enfants. Et ça aboutit à une lettre qui est sortie dans le JASI en 2012 qui disait finalement la question n'est pas de siffler mais parlons plutôt de problèmes respiratoires gênants ou aggravants ou graves pour les enfants, que l'enfant siffle ou ne siffle pas. S'il fait des problèmes respiratoires perturbants pendant plus de 3 jours, on va considérer qu'il a un problème d'asthme. À côté de ces problèmes dits gênants, on s'aperçoit qu'il y a aussi des manifestations entre les épisodes. En dehors des exacerbations, ils peuvent avoir des signes à l'exercice. Et chez l'enfant, c'est surtout quand il joue ou quand il pleure, les enfants qui se mettent à tousser ou à avoir des problèmes respiratoires quand ils pleurent ou quand ils rient beaucoup. La toux nocturne, et les parents se plaignent énormément de cette toux nocturne qui empêche les enfants de dormir. Le fait qu'ils toussent en dehors des rhumes, les réveils nocturnes, le besoin en bêta-2 de secours et là aussi les besoins en bêta-2, en corticoïdes inhalés et la rechute quand on recommence, quand on arrête le traitement. Pour confirmer le fait que parler de sifflement, ça ne suffit pas, il y a ce papier qui a montré que finalement les parents étaient tout à fait capables de reconnaître l'imminence d'une exacerbation. Ils sont capables de vous dire là je sais que mon enfant va être malade et que finalement le symptôme qui allait les alerter le plus souvent c'était la toux. Vous voyez ici le cercle qui montre la fréquence de la toux qui est rapportée par les parents et qui leur permet de reconnaître une exacerbation par rapport à la fréquence des sifflements qui est nettement inférieure. Et souvent, les parents vous disent « Mon fils, je sais, il va avoir une exacerbation parce qu'il se met à tousser et puis il est un peu essoufflé et puis éventuellement il siffle. » Mais finalement, le symptôme le plus frappant, c'est la toux. Et c'est pour ça que se limiter au sifflement, c'est peut-être un peu réducteur. Alors, une fois qu'on s'est dit qu'on avait posé le diagnostic d'asthme du nourrisson sur la survenue de symptômes récidivants respiratoires, la deuxième étape, c'est absolument de se dire est-ce que je suis sûre que je ne suis pas passée à côté d'un autre diagnostic? Parce que chez les petits, c'est ça qui est important, c'est de ne pas se tromper et de ne pas traiter quelque chose qui n'est pas de l'asthme, puisqu'on n'a pas de preuve objective. Et il y a énormément de diagnostics différentiels, parmi lesquels la trachéomalacie ou les pathologies malformatives, mais aussi des problèmes infectieux persistants. Ce qui doit alerter, c'est de se dire c'est pas normal qu'un enfant asthmatique siffle dès la naissance. Un enfant qui est malade dès qu'il est né, c'est un problème malformatif ou congénital, il y a quelque chose. Quand il n'y a pas de rémission, que l'enfant est tout le temps malade, ça n'est pas de l'asthme. Quand il y a un retard de croissance, un petit bébé asthmatique n'a aucun impact sur sa croissance. Quand il a un mauvais état général, et puis quand il y a des signes de gravité comme une cyanose ou un hypocratisme digital, c'est clairement pas de l'asthme, mais il faut aller chercher ailleurs. Et puis, la non-réponse au traitement, mais là aussi, ça dépend de l'adhésion. Et c'est pour ça qu'il est absolument indispensable, et c'est le seul examen complémentaire qui soit indispensable chez les petits, c'est de faire une radiographie du thorax en dehors des symptômes pour vérifier qu'il n'y a pas d'anomalie. Un petit enfant asthmatique, en dehors de la crise, il doit absolument avoir rien. Et là, vous voyez sur cette radio ce trouble de ventilation, et c'était un petit enfant qui était traité depuis 6 mois pour asthme, et ça s'avérait en fait que c'était un corps étranger à l'endoscopie. Alors, pour essayer de mieux comprendre ce qui se passe chez les enfants asthmatiques et pour se dire qu'on allait ajuster le traitement, des classifications en phénotypes ont été proposées et celle-ci a été proposée par le Practal pour essayer de dissocier les enfants qui ne sifflent qu'au cours des épisodes viraux et qui théoriquement n'ont pas d'antécédents d'asthme dans la famille et qui auraient une fonction normale, et je dis bien au conditionnel, qui auraient une fonction normale à l'âge scolaire. Et de l'autre côté du spectre, les enfants qui sont beaucoup plus graves, qui sifflent non seulement au cours des épisodes viraux, mais aussi où les sifflements apparaissent dans d'autres cas, ça peut être une infection virale, ça peut être l'effort, ça peut être des allergènes. Et là, il y aurait des risques importants d'évolution vers l'asthme et la persistance de l'asthme. Une autre façon de voir les choses et peut-être de les approfondir a été proposée récemment par Jocelyne Juste, qui a fait une étude en cluster et qui a identifié 3 phénotypes. Alors, les 3 phénotypes ne sont pas dans cet ordre de fréquence. La surface montre juste la présence de l'atopie ou pas. Parce que les plus fréquents, ce sont bien sûr les sujets qui souffrent de sifflements viraux induits légers et intermittents, donc sans gravité. Mais par contre, elle a identifié 2 clusters qui sont relativement sévères. Les siffleurs atopiques avec des facteurs déclenchants multiples et qui seraient le plus souvent des garçons, et puis les plus sévères et qui seraient plus souvent des filles, qui sont des enfants qui ne sont absolument pas atopiques et qui ont des sifflements ou un asthme difficile à contrôler. Et ceci a été confirmé par l'étude qu'ils ont sortie ensuite sur les phénomènes inflammatoires, où ils retrouvaient de la même façon dans ces phénomènes légers viraux induits très peu de production de NO, alors que dans la forme la plus sévère chez les sujets non atopiques, alors qu'habituellement on a tendance à corréler le NO à l'atopie, c'était les sujets non atopiques les plus sévères qui avaient la production de NO la plus importante. Alors, d'accord, se dire qu'on a dissocié ces enfants en fonction de l'étiologie, il faut essayer de le confirmer par rapport au pronostic de ces enfants. Et quand on regarde le risque d'asthme à 3 ans et demi, les facteurs qui sont associés sont effectivement ceux qu'on pouvait envisager. C'est-à-dire qu'on a d'un côté les problèmes d'atopie et éventuellement héréditaires chez l'asthme chez les parents, les problèmes d'environnement quand on met les enfants sur des matelas qui ont déjà utilisé, toujours le tabagisme maternel bien sûr, mais aussi de l'autre côté, quand on parle des viroses chez l'enfant, et là c'est un autre marqueur, c'est l'utilisation des antibiotiques chez l'enfant, et on voit que plus les enfants ont eu besoin d'antibiotiques et plus le risque d'asthme est élevé. Donc pour ce point, les rapports entre les virus, pour commencer, et l'asthme ont été beaucoup discutés, et parmi eux, les virus qui induisent la bronchiolite. Alors autant le virus respiratoire syncytial, qui est le plus fréquent des virus dans les bronchiolites de l'enfant, n'a pas a priori de relation avec l'asthme, c'est juste une pathologie qu'ont le plus souvent les enfants et qui va pas avoir vraiment de conséquences, alors que les bronchiolites qui surviennent après 3 mois et qui sont moins souvent dues au virus respiratoire syncytial, comme vous le voyez ici, donc ce sont les virus non ARSV qui, elles, vont être prédictives d'asthme ultérieur. Là aussi, on retrouve l'association avec l'atopie, puisque la présence d'une atopie précoce est un facteur prédictif d'asthme, de même que, bien sûr, l'hérédité. Alors, pourquoi les virus, autres que le virus respiratoire syncytial, et essentiellement celui qui est incriminé maintenant, c'est le rhinovirus, c'est-à-dire le virus du rhume tout bêtement, qui est extrêmement fréquent. Alors, ce qu'on a remarqué sur le plan épidémiologique, c'est que finalement, les bronchiolites à rhinovirus étaient très particulières et elles présageaient de la présence d'un asthme ultérieur. Les enfants qui ne vont pas être asthmatiques font une infection à rhinovirus qui n'est pas une bronchiolite. S'ils font une bronchiolite à rhinovirus, c'est qu'ils ont un problème sous-jacent. Pourquoi font-ils des infections à rhinovirus? Probablement parce qu'ils ont un problème de défense immunitaire par rapport à ce virus. En prenant des prélèvements bronchiques, donc d'épithélium bronchique chez ces petits-enfants, et en les mettant en présence de rhinovirus, on s'aperçoit que chez les enfants, qu'ils soient atopiques, non atopiques ou asthmatiques simplement, donc vous voyez que dans les trois populations, les enfants asthmatiques atopiques, les non atopiques asthmatiques et les atopiques non asthmatiques, on a un déficit de réponse par rapport au sujet normal. On a très peu de production d'interférons. Et inversement, bien sûr, on va avoir une réplication virale qui est très importante par rapport au sujet témoin. Donc on permet l'explosion de la réaction virale et donc de l'inflammation qui va en découler. Et ce qu'on suspecte, c'est donc l'importance, plus que d'un déficit au départ, la présence de cellules Th2 qui influencerait la réponse par rapport au virus. Ça ne s'arrête pas au virus, et c'est ce qu'on est en train de remarquer actuellement, c'est que les enfants siffleurs peuvent aussi siffler en réponse à la présence de bactéries. Et c'est une étude qui a été réalisée chez des enfants siffleurs récidivants qui ne répondaient pas à la corticothérapie inhalée, donc ils ont eu droit à une endoscopie bronchique, et ce dont on s'est aperçu, c'est que dans 30% des cas, on identifiait une bactérie dans les sécrétions bronchiques. Et vous voyez que la première bactérie, c'était l'hémophilus influenzae, beaucoup moins souvent d'autres bactéries. Est-ce qu'on pouvait prévoir ça? Effectivement, quand on regardait le lavage à côté, à chaque fois qu'on avait l'identification de l'hémophilus, on retrouvait une cellularité majeure et la présence de neutrophiles. Donc finalement, il est peut-être nécessaire, à chaque fois qu'on a des enfants qui ne répondent pas au traitement, d'aller vérifier qu'il ne s'agit pas d'autre chose et de faire une endoscopie, entre autres pour des prélèvements. Les bactéries sont aussi présentes chez les enfants, chez les nouveau-nés à 1 mois, et ça serait prédictif là aussi de développement de sifflements ultérieurs. Quand les enfants ne sont pas colonisés, le risque de développer des sifflements persistants est très faible, alors que s'ils sont colonisés à 1 mois, le risque de développer les sifflements est multiplié au moins par 2. Quand on a parlé de phénotype, on a parlé initialement de phénotype essentiellement lié à la sévérité ou lié à l'étiologie, mais finalement la première classification en phénotype était une classification évolutive et l'objectif était essentiellement de connaître le pronostic de ces enfants. Et en gros, il y a bien sûr à côté des enfants qui n'ont jamais sifflé, il y a les enfants qui vont siffler très tôt et qui vont perdre leur sifflement rapidement. Il y a les enfants qui vont siffler relativement tard et qui vont continuer à siffler. Et puis, il y a ceux qui sifflent très tôt et qui continuent à siffler inlassablement. Et c'est tout à fait lié au pronostic, puisque vous voyez que les enfants qui ont sifflé dès le plus jeune âge et qui ont continué à siffler, donc ceux qu'on considère comme persistants, ce sont ceux qui ont le plus de risques d'avoir un diagnostic d'asthme à 8 ans, que par contre, le risque de sensibilisation est beaucoup plus lié à l'apparition de sifflements relativement tardifs, donc ceux qui sont considérés comme siffleurs tardifs, et que la chute du VEMS par rapport à ce qui devrait être prédit est aussi retrouvée chez les siffleurs tardifs. Cependant, il y a quelque chose sur lequel je voudrais attirer votre attention, c'est ceci. Les enfants qui sont considérés comme des siffleurs transitoires et chez qui on pense que rien ne va arriver ultérieurement, ils ont quand même, à 8 ans, un VEMS qui est plus bas que les enfants qui n'ont jamais sifflé. Et donc, la question est, quel est le pronostic? Et probablement, il y a un retentissement à l'âge adulte. Cette persistance est liée probablement au remodelage, mais là aussi, ça permet de poser des questions, puisque chez l'enfant, Quand on fait des biopsies chez le tout petit, disons à partir de 2 ans, on va retrouver un remodelage avec l'épaississement de la membrane basale et la présence d'éosinophiles, qu'on ne retrouve pas ici chez les non-siffleurs. Donc là, ce qu'on voit, c'est le remaniement de la membrane basale. Cependant, quand on regarde l'évolution dans le temps, on s'aperçoit que si effectivement, quand ils sont petits, le fait d'avoir un épaississement de la membrane basale, ça distingue les siffleurs des non-siffleurs, ce qui va faire la différence à l'âge scolaire, ça va être la présence d'un épaississement de la couche musculaire lisse par rapport aux non-asthmatiques. Mais que par contre, l'épaississement de la membrane basale n'a plus n'est plus du tout prédictif. Et ça, ce sont les prélèvements qui ont été réalisés quand ils étaient petits. Donc si, quand ils sont petits, ils ont un épaississement de la membrane basale, ça ne veut pas dire qu'ils seront asthmatiques à 6 ans. Et donc là, ça pose la question sur qu'est-ce qui est vraiment un remodelage définitif. Les facteurs de risque de l'asthme donc persistant à 5 ans, c'est là aussi, on leur retrouve les mêmes, l'association d'une part de l'atopie et d'autre part des infections respiratoires. Et c'est essentiellement l'atopie qui apparaît précocement à l'âge de 2 ans. Donc, là, c'est pour confirmer l'association avec le rhinovirus. Mais puisqu'on sait que les bronchiolites, essentiellement celles à rhinovirus, font le lit de l'asthme, la question est, est-ce qu'on peut prévenir cela? Malheureusement, a priori, non. Là, c'est une étude qui a essayé de faire un traitement par corticothérapie inhalée au moment de la première bronchiolite. Donc, première bronchiolite, 15 jours de traitement corticoïde inhalé. À long terme, que s'est-il passé? Absolument rien. Il n'y a aucune différence entre les corticoïdes inhalés et les placebos. Est-ce que pour cela, il faut arrêter la corticothérapie inhalée chez les enfants? Certainement pas. C'est quelque chose qui marche quand eux, ils sont malades, donc pas en préventif, mais en traitement. Et vous voyez ici la courbe bleue des enfants qui sont sous traitement et la courbe rouge des enfants qui ne sont pas sous traitement. Et vous voyez qu'il n'y a pas photo et qu'il faut traiter les enfants. Alors cette courbe a fait beaucoup de bruit quand elle est sortie parce qu'elle démontrait que quand on arrêtait les corticoïdes, les enfants ils se retrouvaient au même endroit. C'est vrai. Donc, a priori, les corticoïdes, quand on les arrête, on retombe malade. Mais ça ne veut pas dire qu'il ne faut pas les utiliser. Ils sont certainement utiles. J'imagine qu'il vaut mieux être un enfant à cet endroit-là qu'un enfant à cet endroit-ci. Il y a une forme particulière à l'enfant qui sont les enfants qui ne sifflent qu'au moment des viroses, mais qui font des exacerbations très sévères. Ils peuvent avoir des périodes entre les viroses qui sont très prolongées, qui sont parfaitement asymptomatiques, mais ils peuvent nécessiter des corticothérapies à chaque fois qu'ils ont leur exacerbation. Et ils peuvent avoir aussi beaucoup plus d'hospitalisation que les autres. Et donc ça, c'est considéré comme les sifflements intermittents sévères de l'enfant, qui est une forme assez particulière. Donc pour prévenir chez ces enfants ces exacerbations, la question est qu'est-ce qu'on peut leur mettre comme traitement? Rien n'a été vraiment prouvé, ce sont juste des avis d'experts. Cette étude était de voir si on pouvait les traiter de façon intermittente, puisque ce sont des enfants qui ne sont pas malades pendant de longues périodes. Eh bien, en fait, qu'on les traite de façon régulière ou de façon intermittente, il n'y a aucune différence sur le recours à la corticothérapie orale. Comme il n'y a pas de bras placebo, on ne sait pas si en fait il faut les traiter. Mais c'est clair qu'on ne sait pas quelle est la meilleure façon. Et finalement, la corticothérapie intermittente n'a pas fait sa preuve. Est-ce qu'on a d'autres moyens de traiter ces enfants? Oui. Un autre produit est utilisé, ce sont les antileucotriènes. Et ça s'est basé essentiellement sur la preuve que les antileucotriènes, quand ils étaient utilisés régulièrement, diminuaient le risque d'exacerbation chez les enfants qui avaient des infections virales. Est-ce que le singulaire, puisque c'est le seul que nous ayons, fait mieux ou fait moins bien que les corticoïdes inhalés? A priori, grosso modo, ils font la même chose chez les petits, puisque quand on regarde si on les met sous corticoïdes ou si on les met sous antileucotriènes, le risque de faire le temps avant la première exacerbation est le même. Ils font un peu plus d'exacerbations par an s'ils sont sous antileucotriène que sous corticoïdes inhalés. De là découlent les recommandations qui sont que chez l'enfant entre 0 et 2 ans, on utilise les bêta-2 mimétiques pour les symptômes, que quand ils ont des sifflements qui ne sont induits que par les virus, on commence par les antileucotriènes, que par contre, quand ils ont des sifflements qui ont plusieurs inducteurs, on commence par la corticothérapie inhalée. Et bien sûr qu'on doit utiliser absolument une chambre d'inhalation avec masque. L'utilisation des corticoïdes oraux durant les épisodes aigus a été une règle depuis de nombreuses années, bien que finalement elle n'ait pas prouvé du tout son efficacité, puisque ça ne diminue pas le risque de l'hospitalisation ni la durée de l'hospitalisation. Par contre, chez les enfants plus grands, c'est à peu près comme chez l'adulte, en sachant qu'on a beaucoup moins de jeux, puisque les bronchodilatateurs de longue durée d'action, les bêta-2, on ne peut pas les utiliser avant 4 ans. La théophiline, on ne peut pas l'utiliser avant 3 ans. Est-ce qu'il y a des choses qu'on peut faire pour prévenir? Probablement augmenter les doses de vitamine D en préventif chez les petits, puisque moins on a de vitamine D et plus on risque de faire d'exacerbation. Il faut absolument demander aux mamans d'arrêter de fumer, parce que le tabagisme passif pendant la grossesse et ensuite, c'est extrêmement nocif et que ça cumule avec la pollution atmosphérique, vous le voyez ici. Donc finalement, pour conclure, je vais vous poser des questions, c'est celles que je me pose tout le temps. Donc, une fois qu'on s'est dit c'est de l'asthme, la première question qu'il va falloir se poser, c'est est-ce que je suis sûre que c'est de l'asthme, est-ce que ça n'est pas autre chose? La deuxième question, ça va être est-ce que ça nécessite un traitement et quel traitement pour ces petits enfants? Et finalement, tout ça, c'est sous-tendu par la grande question qui est qu'est-ce qui advient du remodelage et comment est-ce qu'il progresse? Je vous remercie.
Okay, so we'll keep the questions till the end, and
we welcome Dr. Jim Martin in the second lecture, Sport and Asthma.
Thank you very much. So we actually have phenotypes of presentation. We have presentations by the elderly and presentations by the young. So we're back to the elderly. So my topic is asthma and sport, but I've broadened it to asthma and exercise. Now, the possible associations of asthma with sport are the following. Asthmatics may, in fact, engage in sport without any symptoms whatever. They may have dyspnea on exertion. They may have dyspnea at the beginning of exertion, but they may actually recover in the course of the physical activity. They may have dyspnea and wheezing exclusively post-exercise. In some cases, the practice of sport may actually be associated with an overall worsening of asthma. And of course, there's the question then, are there actually benefits of exercise for asthma? First of all, the physiological responses to exercise, which we know well, and there was a very nice lecture on exercise testing. But you can see here that obviously the heart rate increases linearly with increasing workload or oxygen consumption, and ventilation increases also in this curvilinear manner. Now, usually, I think it's important to note that the heart rate increases from, let's say, 70 to 170, but ventilation may increase from 5 liters a minute to 150 liters a minute. So there's an enormous increase in minute ventilation and stresses that this produces for the respiratory system. The maximum heart rate is predicted in this way, and maximum ventilation is predicted from the FEV1, usually multiplying it by 35. So clearly, under normal circumstances, the heart rate usually reaches a maximum. This is the predicted, but it usually reaches the maximum in a healthy, fit individual on exercise. Ventilation doesn't achieve this particular number because, in fact, you cannot sustain this ventilation for any length of time. This is the predicted maximal available ventilation, but we do not, in fact, usually use all of the available ventilation. So the determinants of maximum exercise are obviously cardiac output, and oxygen delivery to the tissues and its utilization are normally the limit to maximal exercise. However, ventilation also reaches a level where it is probably close to the maximal that can be sustained. So these are fairly well matched, in fact. And of course, it's important to consider peripheral muscle conditioning. So if one is has poor condition of the muscles, one will not exercise very much. So ventilation, obviously, is given by tidal volume and frequency. And we increase tidal volume usually by, obviously, increasing the end inspiratory volume. So we breathe in more, but we also breathe out slightly more, and we go below the normal functional residual capacity. So this is a good strategy, which is not necessarily available to an asthmatic. And the reason for that is that if we look here at the maximum flow volume curve in the asthmatic, this is inspiration and this is expiration, and if we look at tidal breathing here at rest, obviously it's quite a distance away from the maximum flow volume curve. But when the individual starts to exercise and flow and volume increase, eventually the flow and expiration will reach the maximum flow and the individual will be flow limited. Now, of course, as exercise intensity proceeds, and here we're looking at different levels of ventilation from 55, 74, 81 liters per minute, 94 liters per minute. What happens is that in order to recruit the increase in tidal volume, the subject will obviously breathe in more, but will also not succeed in returning to a normal functional residual capacity. So there is progressive hyperinflation that takes place, which has significant consequences for the mechanics of breathing and for the way the person feels when they're exercising. And this is shown a little bit more detail here, and what I'm showing you on the left-hand side is the volume of the rib cage, and this is the volume of the abdomen. In other words, the position of both of these structures. So normally, if we were to take a breath in all the way up to total lung capacity, and if we were to look at the relationship between rib cage volume and the volume of the abdomen, when all of the muscles were perfectly relaxed, in other words, you occlude the mouthpiece, let's say, and you relax all your muscles, the relationship between rib cage and abdomen would follow this particular dotted line. And usually we breathe around that when we're breathing quietly. Now, during exercise, you can see that the abdominal volume gets less. So we move over this way, and the rib cage volume follows this particular trajectory up and down. So the fact that abdominal volume falls means that we push in the abdomen by recruiting expiratory muscles. And this has the advantage of adjusting the length of the diaphragm in particular. This is the relationship between muscle force and the length of the diaphragm, or any skeletal muscle. There is an optimal range for force generation, and if the muscle becomes very short, the force falls off. If it becomes very long, obviously, the force falls off as well. So we have to really work in a range which allows the muscles to generate proper force. And if you were to have an asthma attack and be up here, for example, with a very, very short diaphragm, this would be a significant disadvantage, or a very short intercostal muscles. So that the phenomenon of hyperinflation very much disadvantages the subject because it increases the work, but it also disadvantages the skeletal muscles, the respiratory muscles, from the point of view of displacing them away from their appropriate operating lengths. So this is what we should do on exercise, but we're more likely to move up in this general direction if we are having a concomitant episode of asthma plus exercise. Now, it was mentioned in the previous talk that children often have symptoms of asthma when they exercise. And this is, in fact, a study of athletes that were taken out and run. So they were challenged at a high level of exercise, and their peak expiratory flow was measured following the exercise. Now, you can see on average, this is the sort of 10% line for the change in the peak expiratory flow. Most of the subjects did not drop their peak flow more than 10%, but there were some that did. So that there are, in fact, individuals that are asymptomatic that will develop post-exercise bronchospasm, which, when it becomes clinically significant, we call exercise-induced asthma. Some subjects also, of course, will have no change, and others will actually have some bronchodilation or increase in peak flow following exercise. So this particular phenomenon, which we call exercise-induced asthma, has a tendency to overlap with normal physiological processes, and it's hard to call it a pathology under all circumstances. Of course, if a patient comes into your office complaining, they're asking for treatment, therefore, in a sense, it defines itself as a pathology, but otherwise, it is, when it's an isolated phenomenon, it probably is quasi-physiological, let's say. Now, the relationship between the intensity of exercise and the conditions of the inspired air, these two things will in fact determine the likelihood of exercise-induced bronchospasm. So if, for example, you walk, you jog, or you run, you will have a change in FEV1 that will increase as exercise intensity increases. And if you do this in winter, you're more likely to have extreme bronchospasm than if you do it in the summer, or if you inhale air that is humid and at body temperature. If you do that, you can completely abrogate the response, the bronchoconstriction, to the exercise challenge or to the increase in ventilation. Now, exercise-induced asthma is actually typically post-exercise airway constriction, occurring between 5 and 15 minutes post-exercise usually. It often resolves fairly quickly. It may do so within 30 minutes to an hour. And it's very unusual to have a late response to exercise, although there are some individuals, when they engage in very intense exercise, may have symptoms that actually are fairly prolonged. And I've had some athletes, high-level athletes, that experienced that they had, after intense exercise, had symptoms of expectoration, sputum that lasted for days to weeks. Now, what about dyspnea on exertion? So most of the asthmatics will complain not that they have typical post-exercise symptoms, but will complain about dyspnea on exertion. So the question is this because they're already bronchoconstricted when they exercise, or can you also develop bronchoconstriction during exercise? There's not a lot of literature on this, but this was a paper showing that, in fact, if we look at the left here first, what the patient or the subject has done is to exercise at about 80% of their maximum for a period of about 6 minutes, in this case, or 5 to 6 minutes. Following that intense exercise, there was a fall in the FEV1 by about from 3.3 down to 2.4 liters. Now, in the same subject, if they continued to exercise beyond this point, so they continued exercising beyond this point, eventually there actually was a fall in the FEV1 that occurred during the exercise, although the development of the bronchoconstriction seems to be a little bit delayed over what happens if you have a short burst of intense exercise and then you stop. So it is possible, but not that often studied, obviously for convenience. It's easier to measure the FEV1 when the person stops and can do the maneuver. But if you measure it during exercise, you will find that it will go down. And in fact, if you look at blood gases, in this case saturation, and over here we have the arterial oxygenation. So we have a lot of different subjects here. We have subjects that on the top that actually had very little change in oxygen saturation with exercise. These were asthmatics exercised to exhaustion. And we had the PO2 didn't go down. If anything, it trended upwards. But we had subjects that did desaturate and developed significant hypoxemia during the exercise. So in this particular study, they were divided up into the sort of two groups, but you can see that there's sort of overlap. And you have some asthmatics then that will definitely develop desaturation and hypoxemia, and others that will not during exercise. Now, why would they develop hypoxemia during exercise? This is an illustration of the distribution of gas, in this case hyperpolarized helium, which allows you to image by MRI and shows you a nice homogeneous distribution of gas within the healthy lung. This is an asthmatic that had an FEV1 which was 67% of predicted, so there was significant obstruction, and the FEV1 FVC ratio 65%. But you can see these dramatic abnormalities in ventilation distribution within the lung. And of course, even when the spirometry is quite good, you can find that there are these ventilatory defects within the lung of asthmatics, which we, of course, have no convenient way of measuring. If we could measure these things, we would be more struck by the abnormality than we are on the basis of the FEV1. So, of course, if an individual exercises, the impact of these areas that are underventilated will actually become even greater. And there may be other areas that will participate in this phenomenon of low ventilation perfusion ratios. Now, the theories as to how all this comes about have sort of oscillated between two major groups that have kept the argument alive for quite some time. One is that there are changes in temperature within the airway, and this was a very early study done by McFadden and colleagues where they put a bronchoscope down the airway and they measure the airway stream temperature. And what we're looking at here is the glottis. So this is the distance from the nose down into the lung. But here we have the glottis shown by the arrow, and then we have the main carina here. We have right lower lobe and segmental and subsegmental airways. And what these curves are they're showing us the temperature at different levels of ventilation. So if we look, for example, at 100 liters per minute, the temperature of the at the level of the glottis is about, in this case, 29 Celsius. So that this was room air at 26 degrees with a reasonable amount of water content. So in fact, even if the air is not that cold, when you start to ventilate at high levels, you will cool the airstream and cool the airways significantly. And the reason for that is because you actually lose water by evaporation from the airway surface. And the loss of water is the evaporative heat loss is what causes the cooling. Now, of course, if you do the same thing with cold air, in this case it's minus 18 Celsius and no water content whatever, so very dry, very cold air. And this is showing us temperatures at the carina as a function of ventilation. So in fact, at the carina, you could have a temperature that is as low as 23 Celsius on inspiration. So dry air, and particularly cold dry air, can reduce airstream temperatures very, very dramatically. Now, what are the consequences? Well, first of all, as I mentioned, the airway temperature falls, and the more you ventilate, so the greater the exercise, the farther the fall in temperature will penetrate into the lungs. This results in the release of biochemical mediators, and it's still argued as to which particular cells produce all of the mediators that are important. But we do know that mast cells are activated by this phenomenon. The airways then, of course, react to these mediators, giving us the bronchospasm associated with exercise. And as I mentioned, there were the two major theories. I've just told you about the temperature changes, and the other one relates to the possibility that there's engorgement of the airways by blood. And it's certainly known that if you look at the blood flow, this is blood flow within the mucosa of the airways in normal subjects versus asthmatics, the blood flow is greater in the airway mucosa of the asthmatics. Perhaps not surprising because there's inflammation. We also know that there's vasculogenesis. There's an increase in the number of blood vessels within the mucosa of the asthmatic. Also, the temperature of the expired air is warmer than in the healthy control subjects. So the idea is then that if you cool the airway, this actually increases the blood flow in the airway. So bronchial blood flow is curious and is different from systemic blood flow. If you cool the skin, you will get vasoconstriction. If you cool the airway, you will get vasodilation. And the idea is that perhaps you get an increase in blood volume within the airways that encroaches on the airway and causes problems. I think the idea that cooling the airways triggers the response is, to me, more attractive, but it's still a little bit debated. Now, the people who argued that it was a temperature change have actually tried to argue that there might be a change in osmolarity through evaporation from the airway lining fluid, and that this change in osmolarity, rather than change in temperature per se, is triggering the reaction. But in fact, it's not been possible to show any differences at different levels of ventilation here. Measuring the osmolarity of the lining fluid of the airways, it seems to be fairly stable. So whatever evaporation you get from the airways seems to be compensated for by an increase in blood flow and secretion of fluid into the airway. Now, we know that cysteine leukotrienes are actually involved in exercise-induced bronchoconstriction, and not mentioned earlier that they have a role in viral exacerbations, but they're certainly well documented to be involved here. And this shows you that in the sputum of subjects that have exercise-induced bronchospasm, you have more leukotriene measurable than you do in those that do not have exercise-induced bronchospasm. And there's a relationship actually between the number of epithelial cells within the airways that are shed. So you have epithelial damage and shedding of the cells in proportion to the amount of cysteine leukotriene that is present. Now, how do we diagnose exercise-induced asthma? Well, usually the recommended test is to try and trigger it with exercise. So high-intensity exercise is required for this, and preferably with air that is not too warm and not too humid. You can also do eukapnic voluntary hyperventilation, breathing dry air, and this devices are sold for this purpose, and one can also try and trigger the bronchospasm simply with the stimulus of ventilation. A mannitol challenge has been approved by the International Olympic Committee as a surrogate for exercise provocation. And of course, you could also do methacholine challenge to see whether the individual has reactive airways to methacholine. Now, the agreement, however, between these different tests is not that great, and this is the percent fall in FEV1 with mannitol versus the fall with methacholine, and it's a little bit all over the shop. So even though there's a rough agreement, the agreement is only about 69% between mannitol and methacholine. It's only 62% between mannitol and exercise challenge, and 63% between exercise and methacholine. So all of these tests have their problems of sensitivity and specificity. But if you do an exercise challenge and the FEV1 falls by greater than 10% in the 15 or 20 minutes, 30 minutes after exercise, then you can consider that a positive test and proceed clinically on the basis of that. In reality, if individuals have symptoms, we proceed on the basis of the symptoms and do therapeutic trials. Is exercise good for asthmatics? You could argue that it might be, maybe yes, no, maybe, it depends. So it does depend, in fact. Obviously, in individuals that have exercise-induced bronchospasm, you'd consider that to be bad. But in fact, exercise challenge does not induce airway eosinophilia, even if you induce the same degree of bronchospasm with that as you do with, let's say, a methacholine challenge. If you measure if you do an allergen challenge, I should say, and you measure the eosinophils in the sputum, you'll find them elevated. But if you do a comparable exercise challenge, you will not get any increase in eosinophils. There is a little increase in neutrophils, and that the significance of that is uncertain. So you don't get typical asthmatic inflammation. In fact, there are some experiments using mice where they challenge them with an allergen, ovalbumin, and if you pre-exercise the animals for for a couple of weeks before you challenge them with the allergen, you can attenuate the inflammation, and you can actually, happens without attenuating total IgE, but you do actually reduce specific IgE. So in these animals, the corticosterone levels rise sufficiently to give you a therapeutic effect. But it's not clear that this actually works in humans. There are some special circumstances where the exercise can be adverse. For example, in swimmers, there is a very high prevalence. These are elite swimmers. There's a high prevalence of methacholine hyperresponsiveness. So these are healthy controls. And the swimmers down here that are these elite athletes are comparable to asthmatics in terms of their methacholine responsiveness. And this is also true of cold air athletes, although not quite as much as the swimmers. And the swimmers also have a lot of bronchial epithelial cells that are shed. So it appears that that particular form of exercise may be somewhat more damaging than others. And the reason it is thought is because of the use swimming, in fact, in chlorinated pools, which creates an increase in neutrophils and an increase in eosinophils in these subjects. Just the last point, there is some evidence, however, that swimming training, not necessarily elite athletes that might spend 5 or 6 hours a day in the pool, but swimming training does, in fact, improve the VO2 max of children. It will improve their physical work capacity and their lactic acid threshold, so their fitness as measured in that way improve. It's debatable in adults whether this works. This was a study that was reportedly positive for adult asthmatics. However, there was a Cochrane review that didn't actually agree with that and couldn't find strong evidence in favor of improved asthma control. So I'm not now talking about simply being fitter, but whether your asthma is benefited. I'll finish in 45 seconds, sorry. Treatment is pretty much like all asthma, in fact, but there's perhaps a particular role for anti-leukotrienes in the treatment. Short-acting beta agonists are extremely useful. Single administrations of a long-acting beta agonist would also work, but if you use long-acting beta agonists on a regular basis, you will lose the protective effect, the prophylactic effect of the beta agonist on the exercise-induced bronchospasm. Inhaled steroids will also improve the situation, and in fact, pretty much all of the asthma medications have been useful. So short-acting beta agonists are excellent to protect. All therapies have some efficacy. Regular beta agonist use worsens exercise-induced asthma and leads to desensitization and tolerance, and therefore one has to be careful to avoid that. This just shows us that montelukast will attenuate the post-exercise bronchospasm. And I'll stop there since I've run out of time, and maybe we can deal with these issues in the question.
If you said 45 seconds, you still have 5 seconds.
Oh, I do, okay. So just the conclusions are that exercise is associated with increased airway narrowing in many asthmatics. Bronchoconstriction may occur after exercise, which is classic exercise-induced asthma, but it can also develop during exercise. Cooling of the airways is likely to be the trigger. High-level sports, swimming in particular, may predispose to inflammation of the airways. This is really excessive exercise, you might consider. Exercise, however, in moderation will improve aerobic capacity in asthmatics, and the treatment certainly does need to be individualized. So thank you very much.
Dr. Hamzawi and Dr. James, thank you very much for the interesting, informative, and clearly stated conferences, and right on time. I think we still have 10 minutes till 6:30, so we open the floor for questions and answers.
Je veux vous poser la question, s'il vous plaît, suivante. Vous avez dit que les utilisations des antibiotiques chez les enfants peuvent aggraver le tableau d'une infection, plutôt d'un asthme. Et on sait très bien que les asthmatiques, surtout chez les enfants, font des infections à répétition. Première question, quel est où on peut donner les antibiotiques? Devant n'importe quelle fièvre, on peut donner des antibiotiques ou non? Et deuxième question, si l'enfant déjà a été traité par les antipyrétiques, à répétition et la température reste telle qu'elle est, ou on peut donner les antibiotiques.
Merci beaucoup.
Non, il y a encore 2 questions, s'il vous plaît. D'accord, j'attends votre réponse première.
D'accord, merci. Les antibiotiques sont des marqueurs, en fait, de la fréquence des infections. Ce ne sont pas eux qui déclenchent l'asthme ni qui déclenchent la crise. Simplement, ils ont été utilisés comme marqueurs. Plus on a besoin, enfin, plus les médecins prescrivent d'antibiotiques, plus ça veut dire qu'on a fait des infections respiratoires. Maintenant, jusqu'à très récemment, on considérait que chez les enfants, ce qui déclenchait les crises, ça n'était que les virus. Donc, du coup, on n'a pas mis d'antibiotiques du tout pendant très longtemps. Je crois que ça continue à être la règle parce que les enfants qui font des crises d'asthme, le plus souvent, c'est viral et il n'y a pas besoin d'antibiotiques. Même si ça dure une semaine, en général, une virose, ça dure une semaine. Maintenant, est-ce qu'il va falloir chercher des bactéries chez des enfants chez qui les symptômes persistent plus longtemps, les enfants qui sifflent sans arrêt, que vous n'arrivez pas à améliorer malgré le traitement? Là, la question est oui, mais la question est, il faut aller les chercher de façon agressive, c'est-à-dire il va falloir faire des endoscopies, et on ne sait pas encore si, quand on trouve un germe, quelle est la durée du traitement. Probablement, il va falloir faire un traitement relativement prolongé pour nettoyer.
Any other questions? We have 5 minutes more, so you'll have your turn after that.
Dr. Martin, asthma and sports. For people who are making exercise 3 times a week or 4 times a week, do you put them on a regular treatment for asthma and plus just before sport? What do you? This is a very practical.
Yes. So my approach is if the person exercises not very regularly, then I think short-acting beta agonist is the treatment of choice. If they have perfectly normal airway function in between those episodes. Many of them actually have asthma through other triggers, and if you measure spirometry, it's not normal, and therefore I treat them on a regular basis. But for the isolated cases, PRN, beta agonist before exercise is okay. If the person is exercising 3 times a week, I consider that excessive use of beta agonist to use it only. Therefore, I prescribe inhaled corticosteroids, and if they are not sufficient, I then just treat as regular asthma. Yeah. And then sometimes I'll give an inhaled corticosteroid, and if the protection isn't sufficient, I may try an anti-leukotriene in combination and see if that does it.
Dr. Hon.
My question is, what about exercise-induced asthma in persistent asthmatic people, very well treated, but they have always exercise-induced asthma, even in full treatment of their asthma and documented by pulmonary function test? What we can do in this case? They are fully treated with all medication, but they couldn't do their exercise or effort. Do you have this kind of people?
Yes, so, I mean, there are occasionally individuals that will still have exercise-induced symptoms. Do you mean after exercise or during exercise? During exercise, yeah. That's right. So they cannot exercise. That's correct. So, I mean, you can only give the maximum amount of treatment, and then you're sort of stuck. The problem with when we use a combination of long-acting beta agonists and steroids, the regular use of long-acting beta agonists loses its protection against the exercise-induced symptoms. So I make sure that I try anti-leukotrienes in all those individuals. If it doesn't work, it doesn't work. I mean, they have to live within their limits. If their asthma is bad enough in other ways and they have exacerbations repeatedly, then we can consider anti-IgE therapy. But I haven't seen any studies looking at the effects of anti-IgE on exercise-induced bronchospasm, to be honest.
Next.
Excuse me. For a patient who's not asthmatic and they have some induced episode of asthma and during exercise, this kind of people, did you treat before doing exercise or no? Did you give any treatment or no?
Yes, so I just recommend short-acting salbutamol before exercise, because salbutamol, even if you're taking it regularly and it causes some degree of desensitization, if you take it right before exercise, it's still protective. So it's a good choice. So salbutamol before exercise, 15 or 20 minutes beforehand, is a good way to inhibit the exercise-induced bronchospasm.
It's for non-asthmatic usually people,
well,
yes?
Yeah, you can argue if this is asthma or this is not asthma, but for somebody who just has this very isolated event, that's the recommendation. Yeah.
Pour Agnès, est-ce que le CBC peut apporter quelque chose dans le diagnostic bactériologique après des séances de kiné, ou est-ce qu'il faut passer directement à la fibro qui reste un examen invasif?
Il n'y a pas vraiment de preuves. Mais disons que dans les études, souvent le CBC n'est ni sensible ni spécifique. Et on peut passer à côté de germes. Donc la recommandation, c'est quand tu as vraiment un enfant qui est très symptomatique, il faut aller à l'endoscopie. Qui n'est pas un geste si agressif que ça, finalement, chez les enfants. Ils ont tendance à bien tolérer ça.
Agnès, merci pour cet exposé très complet. Juste une petite remarque par rapport au reflux, parce que ça, c'est casse-tête des fois, le reflux gastro-œsophagien qui revient, et c'est vrai que dans les études, là, on n'a pas vu le sujet abordé. Et deuxièmement, ce n'est pas le problème, je pense, j'allais dire en France, au Liban ni en Tunisie, peut-être la sensibilisation par rapport aux aliments dès la naissance aussi. C'est la théorie TH1, TH2, etc. En deux mots, bien entendu.
Oui, alors par rapport au reflux, c'est toujours la question, mais finalement, on a tendance à surestimer l'impact du reflux. Le reflux, ça fait tousser, ça fait des fausses routes, mais ça ne fait pas franchement siffler. Et il vaut mieux, à mon sens, et je pense que c'est le sens des études, il vaut mieux commencer par traiter l'asthme, et si ça ne marche pas, aller chercher un reflux et traiter le reflux plutôt que faire l'inverse, parce que quasiment tous les enfants qui toussent vont avoir un reflux, mais ce n'est pas nécessairement ça la cause du problème. Par rapport à ta deuxième question, c'était sur l'âge d'introduction des aliments. Les recommandations actuelles, c'est à partir de 4 mois, donc utiliser la fenêtre entre 4 et 6 mois pour faire la diversification alimentaire. Et par contre, proposer plutôt l'allaitement maternel le plus longtemps possible, disons au moins 6 à 7 mois. C'est ce qu'on propose. Nous, notre problème sur la diversification alimentaire, c'est d'abord qu'on donne du lait en boîte classique à des tout petits bébés, parce que les gens n'ont pas les moyens de s'acheter du lait en poudre et ils ne suivent pas les recommandations d'allaitement maternel. Et le deuxième problème, je ne sais pas si vous avez la même chose au Liban, nous on a un énorme problème avec les fruits secs qu'on donne très vite aux enfants pour les rendre intelligents. Donc c'est bien dans un sens parce qu'on a très peu d'allergies aux fruits secs, mais l'inconvénient c'est qu'ils font des inhalations de corps étrangers de façon très fréquente et on a donc des soucis avec ça.
Thank you very much.